And an internist by training, he has spent much of his career working to enhance the role of prevention and primary care and to improve care for medically underserved populations. In addition to practicing primary care medicine for more than 15 years, he has served in several administrative roles, including that of Health Center Medical Director. Prior to joining the AACS, Dr. Brooks completed the Commonwealth Fund Harvard University Fellowship in Minority Health Policy, followed by 1 year term as a senior health policy intern in the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Dr. Brooks is an Ohio native and received his medical degree from Wright State University School of Medicine in Dayton, Ohio, where he subsequently completed his internal medicine residency and served as chief resident. He also holds a master's degree in public health from the Harvard School of Public Health. Dr. Brooks, I'll turn it over to you.
Thank you, Brooke. I got to make sure to send a briefer bio next time. Thanks to everybody who's on the line for joining us to talk about this very important issue. And I have a lot of, I believe, very interesting and useful information to share with you. I want to do a little level setting and just point out that colorectal cancer remains extremely common. 145,000 plus new cases are expected this year, and more than 51,000 Americans are going to die of this disease, making it the second leading cause of cancer death. The good news is more than 1 million Americans are currently living with or have defeated colorectal cancer. Many people have been treated effectively and been able to move on with their lives, but many people are fighting the disease right now. We've seen a very dramatic fall in colorectal cancer deaths in the U.S. going back for more than 3 decades now. And this fall accelerated dramatically during the last decade in the 2000s. A big part of that is because we've improved our ability to treat the disease over the last 30 years, but certainly screening plays a huge role as well. Screening allows us to find and remove polyps and prevent cancer entirely, but also screening allows us to find cancer at earlier stages when it's more amenable to our treatments. As you can see from this graph, individuals who are diagnosed with localized colorectal cancer have a 90% chance of being alive 5 years later. That compares to only a 14% 5-year survival for those people who have metastatic disease at the time of diagnosis. And we're much more likely to find the disease early if we're screening. But right now, we're only finding about 39% of cases in that earliest, most treatable stage. So we need to be doing a better job with our screening efforts. Across the nation in 2016, which is the latest data we have from Centers for Disease Control, about 68.9% of US adults over the age of 50 were up to date. In South Dakota, that number was 66.9, so a little under the overall US average. And actually that number puts South Dakota in the lower third of states with regard to screening. It also means that basically 1 out of every 3 South Dakotans who should be screened is not up to date with screening. And if you look at specific groups, Hispanics and Native Americans, screening rates are even worse. And then regardless of race or ethnicity, those individuals who have low income, low educational level, or are uninsured are much less likely to be screened. That's across all racial and ethnic groups. So I'm going to talk about recently updated ACS screening recommendations, but I want to point out that the recommendations I'm going to be talking about are for average risk individuals. It is imperative that you know who the high-risk individuals in your practice are. And people who have a personal history of adenomatous polyps or colorectal cancer, a personal history of inflammatory bowel disease, a family history of colorectal cancer, or very importantly, a family history of adenomas also increases risk. So you need to be finding these folks well before the age of 40 or 45 or 50, because recommendations are that they begin screening, for instance, those people who have a family history. If mom was diagnosed with colorectal cancer at age 52, then that child needs to start screening at age 42. So you've got to be asking people questions and collecting this information in order to make sure you're starting screening at the right age. Now, with regard to the overall average risk population, in May of 2018, the ACS broke with tradition. For many, many years, 50 had been the starting age for average risk screening, but looking at new data, some of which I'll be sharing with you, it became clear to us that that frankly is too late. And we now recommend everyone 45 and older be screened for colorectal cancer. Everyone at average risk of the disease be screened with colorectal cancer. And that patients be offered the opportunity either for a structural exam, such as colonoscopy, or a high sensitivity stool-based approach to screening. We also reinforce the importance for individuals who choose a stool test as their first approach. It is imperative that they have appropriate follow-up, which means they need a colonoscopy, because there's unfortunately a lot of evidence indicating that people are not getting that follow-up examination. With regard to the overall options under stool testing, there are 3 different types. The fecal immunochemical test, which I'll talk about in some detail. There are older guaiac tests, only the high sensitivity versions recommended. And then there is the multi-target stool DNA test, COLOGUARD being the one brand that's on the market. Under structural exams, colonoscopy, the CT colonography or virtual colonoscopy, and FLEX-SIG all have evidence supporting their value. So patients should be made aware that there is more than one test for colorectal cancer screening, and offered the opportunity to choose at least one from each of these groups. When you compare our guidelines with those of the Preventive Services Task Force published in 2016, there's actually very little difference. The age 45 starting is really the primary difference. With regard to the various tests that are recommended, the lists are almost identical. And with regard to when to stop screening, it's also important to recognize that there is good evidence that for people who are in good health, and particularly who have not been screened regularly, that continuing screening in the 70s and early 80s may be worthwhile. The Preventive Services Task Force and the ACS both recommend that the decision about stopping screening should be individualized in individuals between 76 and 85. So you don't just stop because somebody crosses that 75-year threshold, but you have to look at their overall health status, their past screening history, and then make a decision based on what's going to be best for them. After age 85, there is really no evidence that we're going to do benefit, and quite likely are going to harm people if we continue screening. Now, I mentioned evidence that led us to this earlier age of recommending screening. A big part of it is just the epidemiologic evidence demonstrating that we have seen a dramatic increase in colorectal cancer, both incidence and mortality, in people in their 20s, 30s, and particularly 40s. There's been a 51% increase in colorectal cancer diagnosis before age 50 over just the last 20 years, a 51% increase. And most of this increase is occurring among people who are in their 40s, although we're seeing more and more cases among people in their 20s and their 30s. So if you look back at 1990, 6.4% of colorectal cancers diagnosed in the US occurred in people under the age of 50. By 2015, only 15 years later, that number had essentially doubled. So now more than 12% of individuals diagnosed with colorectal cancer in the US each year are under the age of 50. And the bulk of those folks are in the age group of 45 to 49. So looking at this and a wealth of other data to the ACS, it's pretty clear that 45 has become the new 50. As a matter of fact, we looked at the distribution of disease, the incidence rates, back when we first started recommending colorectal cancer screening for people age 50 and older, and that was back in the late 80s and early 90s. And the current incidence rate for colorectal cancer among people age 45 is the same as it was for people age 50 back in the early 90s. So 45 truly has become the new 50. This trend has been going up for every racial and ethnic group. These lines represent different racial and ethnic groups, but that orange line at the top is the Native American and Alaska Native population. And while rates are rising for everyone, they're rising dramatically and much faster for that group. And we don't really know why. As a matter of fact, we don't know why the rates are rising for anyone. There are a lot of theories and conjectures. There's a lot of work underway trying to figure out what the pieces are. But we do know that the environment in which people are living and growing today has changed dramatically. We have much higher rates of obesity than we had 30 or 40 years ago, and obesity is a prime risk factor for colorectal cancer. Red and processed meats, lunch meats, bologna, hot dogs, those kinds of things. Red meat consumption and processed meat consumption has risen also very dramatically over the last 30 or 40 years. Type 2 diabetes is a known risk factor for colorectal cancer. And when I was in practice 20 years ago, I don't ever recall seeing anybody under age 30 with type 2 diabetes. And the vast majority of my type 2 diabetics were in their late 30s, 40s, or much older. And now I understand from my practicing colleagues that it's not unusual to see people in their early 20s and sometimes their teens with type 2 diabetes. The other factors, potential factors, include our use of antibiotics, hormone use, and as well as pesticides and other things. There is not strong evidence around any of these, and there certainly is no single magic bullet that we can point to and say, aha, this is why rates are rising. But we do know that the rates are rising, and one step that the ACS feels is going to help is to begin screening at an earlier age. Now, one other important thing, I mentioned earlier the fact that some people are at increased risk, and therefore, even based on old ACS guidelines, based on guidelines from the Preventive Services Task Force and other organizations, these people should already be getting screened well before the age of 50. These are folks who have those personal risk factors, but also have family history. This study that is referenced in this graph was performed just a couple of years ago. And this was a group of patients at Ohio State University, all of whom were under 50 when they were diagnosed with colorectal cancer. And then a careful review of patient history and patient medical records revealed 44% of these patients actually had risk factors that should have led them to start screening before age 50, yet none of them had been screened before 50. So they were diagnosed with cancer before the age of 50. None of them had been screened. And they all had risk factors, family history risk factors or other, that should have led them to get screened. So one of the things we have to do is we've got to do a better job at identifying those folks who we know are at risk of early onset disease and beginning screening earlier. To that end, the ACS and the National Colorectal Cancer Roundtable joined forces to create this toolkit to help primary care practices do a better job of both assessing and responding to patient risk related to colorectal cancer. And this is available at the NCCRT website. Now, the other thing that we can do is raise awareness both among clinicians and among patients that colorectal cancer before the age of 50 is no longer a rare occurrence. In many instances, because of my work, I talk to a lot of young survivors, people who are diagnosed with colorectal cancer in their 40s, their 30s. As a matter of fact, just yesterday, I met a young man who was diagnosed at age 26. And I hear the same story over and over from these various folks. That is, they had symptoms, abdominal pain, changes in weight, or blood in their stool. They went to the doctor, they went to the emergency room, and they were repeatedly told, oh, it must just be hemorrhoids, or oh, you must have an ulcer, oh, you're way too young for colorectal cancer, so we don't need to worry about that. There is really, at this point, no age at which you can tell someone they're too young for colorectal cancer. So if you see a patient who is in their 30s, but they're having symptoms that if you saw those symptoms in a 60-year-old, you would immediately send them for colonoscopy, you need to treat that 30-year-old the same way. You have to respond to symptoms and realize screening recommendations are for individuals who don't have any signs or symptoms of disease. When somebody presents with symptoms, regardless of age, you need to take a new approach to them. So I showed you that long list of screening tests that are recommended both by ACS and the Preventive Services Task Force. But the reality is when we look at what's going on across the country, the vast majority of screening is right now via either colonoscopy or stool tests looking for hidden blood. Colonoscopy, everyone's familiar with, long lighted tube, camera on the end, looks at the entire length of the colon, has some real advantages in that it is a screening exam, but it's also diagnostic because you can take biopsies during the procedure and see what you're dealing with, and it is therapeutic. The vast majority of polyps that are found during a colonoscopy are removed during that same procedure. So screening, diagnostic, therapeutic. In addition, if it is completely normal and a high quality exam, that patient doesn't need any other screening tests for the next 10 years. Now, if a patient has a colonoscopy and then a year, 2, 3 years later, they develop symptoms, remember, screening is about people who have no symptoms. If someone develops symptoms, even if they had a recent colonoscopy, you need to at least give consideration to whether or not another colonoscopy may be warranted if they develop new symptoms, because unfortunately, as I'm going to point out, things get missed during colonoscopy. But for patients who have a normal exam and remain asymptomatic and you're confident it's a high quality exam, there's really no point to ordering stool tests in between normal colonoscopies. You're likely to do more harm than good. Now, colonoscopy is by far the most commonly used test. Close to 90% of screening in the US is via colonoscopy. But colonoscopy is not a perfect test, although it's sometimes framed that way. Colonoscopy misses up to 10% of significant abnormalities, and that's been shown in a number of different studies. In addition, it is far more costly on a one-time basis, and particularly for people who are uninsured or underinsured, the costs may simply make it out of reach for them. It also has a higher potential for patient injury. It's a very good and a very safe test overall, but somewhere between 1 in 500 to 1 in 1,000 individuals undergoing screening colonoscopy are going to end up with a complication that requires additional medical care. Sometimes that means a little bit of bleeding and they show up in the emergency room. Sometimes it means a lot of bleeding and they have to have a transfusion. Perforations are not rare occurrences. In addition, we're talking about doing this test in people in their 60s and 70s, and both cardiovascular and cerebrovascular events are a real risk. So good test, safe test overall, but does have some potential challenges. And one huge challenge that many clinicians and most patients have no idea about is the very wide variation in the quality of colonoscopy as it's currently practiced. Now, there have been improvements over the last 15 years or so, and the GI organizations have all developed quality metrics and recommend that everyone doing colonoscopy is collecting data on these quality metrics. And one of the metrics that has really sort of jumped out to the top is the adenoma detection rate. And the adenoma detection rate is the proportion of patients in which an endoscopist finds an adenoma. The adenomas are shockingly common. As a matter of fact, adenomas should be present if you're looking at an average risk screening population over the age of 50. Usually you're going to find adenomas in about 30% of men undergoing screening and 20% of women. So in a mixed gender population, if I'm screening 100 men and women combined, I should be finding an adenoma 25% of the time, or basically 1 out of every 4 procedures. Yet, studies have demonstrated that even in large integrated medical groups where they're seeing the same kinds of patients, using the same equipment, working with the same support staff, the adenoma detection rate can be extremely variable. Remember, the normal or the rate, the target adenoma detection rate is about 25%. Studies have shown that some endoscopists find adenomas up to 50% of the time. But others, in one large study from KAISER, for instance, only 7% of the time were they finding adenomas. So unless their patients were somehow dramatically different from those of all of their colleagues, that means people were missing a lot of disease. And study after study has demonstrated pretty wide differences in gastroenterologists and endoscopists' ability to detect adenomas. But we also know from this KAISER study and from other studies that a low adenoma detection rate has negative consequences for patients. Looking at more than 300,000 procedures over about a 12-year period, and following up those patients, what they found at KAISER was patients who were treated by endoscopists who had the low adenoma detection rate, the lowest rates. That, in this case, that was simply an adenoma detection rate under 20%. So they were finding adenomas in less than 1 out of 5 patients, when the target number is at least 1 out of 4. If the adenoma detection rate was low, patients were twice as likely to be diagnosed with cancer before the next colonoscopy was due. So within that next 5, 6, 7 years, patients were twice as likely to be diagnosed with cancer than if they were treated by those clinicians who had the highest, the best adenoma detection rates. And patients were 3 times as likely to die from colorectal cancer if they were treated by those clinicians who had low adenoma detection rates. So a number of other studies have supported the fact that low adenoma detection rates by an endoscopist are associated with worse outcomes for their patients. Yet in many settings, you just don't know what the adenoma detection rate of the endoscopists are. There are more and more places where this data is being collected and is publicly available. And I will tell you that I have been encouraging primary care clinicians, if they have more than one place to send their patients for endoscopy, to ask the endoscopist, are you collecting these quality measures? Are you willing to share your quality measures? In particular, what is your adenoma detection rate? And if you've got centers that are willing to share that information and their ADR is 25% or better, then you can have a higher level of confidence that your patients are getting high quality exams. So when you have the opportunity, at least asking about this. And I think over the next 5 to 10 years, this is going to become one of those things that is available and that, frankly, different endoscopists are going to be promoting their ADRs. Now, there are a few other shortcomings or challenges with colonoscopy that also have to be kept in mind. The bowel prep. Patients, by and large, hate the bowel prep. I've had many patients come back after the procedure and tell me, oh, the colonoscopy, that was easy, but the bowel prep was horrible. Please don't make me do that again. It also requires that patients go somewhere and have someone drive them and stay with them throughout the procedure. So for a lot of patients, that's a real big barrier. In addition, access can be limited by insurance status, and actually in your state, access can be limited solely by geography. I'm sure there are parts of the state where people have to drive for a couple of hours just to get to endoscopy. And then a final factor that turns out to be a lot more important than we realized a decade ago is that many patients just do not want an invasive exam. And even if they have geographic access, even if they have insurance, they don't want an invasive test like colonoscopy. Now, most patients will not tell you that, but their behavior will tell you, because you'll make the referral and they don't show up. And then you make another referral and they don't show up. What's been found when we've actually asked patients about their preferences is that many patients prefer stool testing over colonoscopy. This is a study done in a hospital setting a few years ago. And they had 1,200 patients, all of whom were overdue for colorectal screening. So they educated the patients about screening and why it was important. And then they told one group, you can have a colonoscopy free, no charge, just go get the test. Another group was told, take these kits home, collect stool specimens, and return them. Third group was told, you can have a colonoscopy, you can do stool testing, you choose. The group that was only offered stool testing, that's the gray bar on your left, 67%, 2 out of 3 of those patients completed their screening during the study period. Patients who were only offered colonoscopy, a free colonoscopy, less than 4 out of 10 of those folks completed their screening, only 38%. And patients who were given a choice, again, 2/3 of those folks completed screening, but notice more of them actually chose stool testing than colonoscopy. Study after study has demonstrated that if you give patients a choice, anywhere from 25 to 50% of patients will choose stool testing over colonoscopy. Yet in most settings, patients are never given that choice. So when we talk about stool testing, again, the most commonly types used right now are tests that look for hidden blood, and those include older guaiac tests like Hemoccult and Hemoccult-2, which actually are no longer recommended for colorectal screening. They're still used, unfortunately, but they're not in the Preventive Services Task Force guidelines, the ACS guidelines, the GI Society guidelines. That's gone. Fecal immunochemical testing has really supplanted the use of guaiac tests in most environments for a number of reasons that I'll share with you. And then there's the new kid on the block. There are tests that look for abnormal DNA, and the one that's in the marketplace is COLOGUARD, and I'll talk about that one briefly as well. But one thing to keep in mind is that stool tests are only for average risk patients. So going back to that first slide I showed you with about screening recommendations, patients who have those risk factors, family history or personal history risk factors, are not average risk, and therefore colonoscopy is what's recommended for the vast majority of those patients. Now, fecal immunochemical test, also called FIT test, also called IFOB or IFOBTs, all of these are the same kinds of tests, and these use an immunoassay to detect human blood, so they are much more specific than guaiac tests. And because of that higher specificity, you get many fewer false positives. And these tests also, many of the tests that are in the market only require collecting one specimen as opposed to 3. And there have been a couple of studies indicating that patients are more likely to complete stool testing if they've only got to collect one stool specimen instead of the 3 that are required by all of the guaiac tests. In addition, these tests are much more sensitive than any of the older forms of guaiac testing. So again, fecal immunochemical tests have really kind of taken over from guaiac test in most environments. If you are still using a guaiac test, the only guaiac test that's included in guidelines from any major organization is Hemoccult-Sensa, which is a hypersensitive guaiac test. But the high quality FITs are still superior to Hemoccult-Sensa when it comes to detecting cancers. Now, do these tests actually work though? It's important to recognize that we started doing colorectal cancer screening based on results from studies using older guaiac tests. And even with those lower sensitivity versions of the test, we have 3 studies that showed you can decrease colorectal cancer mortality by doing regular screening. But in the current era, as I mentioned, colonoscopy is much more commonly used, and there are many clinicians who just don't believe that stool testing is effective anymore. The reality is that if you look at long-term, well-done, high-quality stool testing, you get very good outcomes. This graph shows some modeling data from the U.S. Preventive Services Task Force. When they updated their guidelines a few years ago, they had modelers estimate the impact of screening by various methods on colorectal cancer outcomes. And this shows the likelihood of death or avoidance of death based on screening. COL10Y on your right, you see that for every 1,000 individuals screened, we can prevent 24 deaths from colorectal cancer. That is a huge return on our investment. Preventing 24 deaths for every 1,000 individuals that we screen is better than just about anything else that we do in medicine. On the other hand, if you look at the other end of this scale, FIT1Y, that's doing FIT tests every year, and you avoid 22 deaths from colorectal cancer. So is 24 better than 22? Sure. Is 24 strikingly, massively better than 22? Not so much. It's a relatively small difference when you start looking at large populations. And when you also take into account the fact that because FIT testing is so much less expensive, FIT testing in most instances is less than a $30 test, colonoscopy in most places is $2,000 and up. So you can screen many, many more people with FIT testing, and access isn't, again, limited by geography or insurance or those other kinds of issues. So FIT has a number of advantages. One, far less expensive. It doesn't require that bowel prep, which most patients hate. It's done in privacy at home, which turns out to be something really important to a lot of patients. They don't have to go anywhere, take time off work, tie up to anybody else. It's non-invasive. There really is no risk from collecting a stool specimen, at least none I'm aware of. And if you are in an environment where colonoscopy is a relatively limited resource, then FIT is really a very good alternative because it cuts down on the need for colonoscopy, and you can use those limited numbers of colonoscopies only for those patients who are at highest risk. On the left is an example of a screening program that is solely colonoscopy focused. So you're going to screen 1,000 patients using colonoscopy. After you do those colonoscopies, you're going to find one cancer in every 400 to 1,000 colonoscopies. So you screen 1,000 people, you find one, maybe two, at most 3 cancers out of 1,000 colonoscopies. On the other hand, if you do FIT testing, number one, you can screen many, many more people because it doesn't have the same logistical or financial barriers. So you start off with 2,000 people, you do FIT on all of them. Of those, you're going to have a pretty small number, usually somewhere in the range of 10% or less. So out of those 2,000 people, maybe 200 of them have a positive FIT test. And so now, instead of doing 1,000 colonoscopies, you've only got to do 200 or less. But you've identified patients through FIT testing who are at significantly higher risk. So you're going to find a cancer in maybe 1 out of every 20 of those folks. So you're going to find more cancers while you're doing far fewer colonoscopies. Now, again, I have to emphasize, stool testing is only for average risk patients. You have to be using the newer high quality version. So either a FIT test or Hemoccult Sensa. And it is imperative that everyone who has a positive finding on stool testing undergo colonoscopy. You cannot say, oh, well, maybe they didn't follow the diet. Oh, maybe it's hemorrhoids. Oh, maybe. No, a positive FIT test, a positive Hemoccult test is cancer until proven otherwise, and you must do colonoscopy. Unfortunately, in many settings, less than 75% of folks, and oftentimes only about half of people actually get that follow-up colonoscopy. So if there's time at the end, I'm going to talk about some ways to hopefully increase those numbers. All the information that I've just shared with you about stool testing is outlined in this reference tool that you can find at the NCCRT website. COLOGUARD also is mentioned in that reference tool, and I do just want to take a moment to talk about COLOGUARD because its use certainly seems to be growing in the U.S. COLOGUARD actually is a combo test. It's not just a stool DNA marker test. It has markers. It looks for markers that are associated with cancer and with adenomas, but it also combines that with a fecal immunochemical test. In the largest study to date of COLOGUARD, this was more than 10,000 people undergoing screening colonoscopy. Of those patients that had cancer found at that colonoscopy, more than 90% of those cancers were detected by COLOGUARD, by the combination of DNA marker and FIT markers. It also found 42% of what they call advanced adenomas, those kinds of adenomas that are known to progress to cancer. So 42% is better than most stool testing. Probably 20 to 25% is what you find for guaiac or immunochemical testing when it comes to polyps. But 90% cancer sensitivity is really the number that you really have to keep in mind. And I think that's the number that ended up helping COLOGUARD get into the U.S. Preventive Services Task Force guidelines, as well as some of the other quality measures it's in now. So it's included in the guidelines both from ACS and the task force. It also is now a HEDIS measure. So patients who have COLOGUARD testing are up to date for the next 3 years under HEDIS, and the Uniform Data System, the system that's used in federally qualified health centers, also includes COLOGUARD as a reasonable approach to colorectal screening. It's recommended every 3 years. That 3-year number, the evidence supporting it is relatively soft, but the company is actually in the process of collecting data and trying to determine whether 3 years is actually the right interval, but that's what's recommended right now. It is covered by Medicare, and private insurance actually has begun covering more and more patients since it was added to the task force guidelines a couple of years ago. It has higher sensitivity for cancer, but it has lower specificity, meaning you get more false positives. So you're going to end up sending more patients to colonoscopy. And every positive has to be evaluated by colonoscopy. And then one thing that is included in that cost for COLOGUARD is actually a patient navigation component. That is, when you write the prescription for COLOGUARD, the company takes over and they track the patient, they send information out, educational information, they call them, they send the collection kit out, and then they collect the kit. So they do a lot of work that many primary care practices just don't have the time or the bandwidth to take on. I'm going to talk briefly about some interventions that have been shown to help boost screening rates. Standing orders. The more we can delegate and share responsibilities across a practice environment, the better we're going to do at preventive care overall. This is not specific to colorectal cancer, but it works for colorectal cancer. So having medical assistants or nurses have the initial discussion about colorectal cancer screening, potentially even providing the patient with FIT kits and educating them about how to collect the specimen. And then the clinician, their responsibility really becomes simply reinforcing the importance of the patient completing that test, or having, again, the medical assistant or the nurse go ahead and make the appointment for the colonoscopy while the patient's waiting to see the clinician. And the clinician becomes kind of the co-signer and helps to impress how important that issue is. Another approach that has been shown to be very helpful in a number of environments is what's called direct endoscopy referral, where the patient does not get a referral to go see a gastroenterologist or surgeon and then have to make an appointment, go to that person's office, talk to them for 5 minutes, have their belly poked on, and then make another appointment to go for the procedure. So the ability to bypass that office visit and go straight from the primary care office to a colonoscopy appointment has been shown to significantly increase the likelihood of patients completing that colonoscopy. And it turns out this is actually a very safe approach for probably 90% of endoscopy patients. So there are checklists and forms that have been created and criteria that you have to simply check off within your primary care environment. But this requires a partnership between primary care and endoscopy. The GI organizations have created tools to help with this also, and to help educate primary care clinicians and endoscopists, and to help facilitate this kind of smooth transfer. And it can go a long way toward getting patients, by eliminating that extra visit, getting patients to complete their colonoscopy. The electronic medical record has the potential to be a great resource to help boost colorectal cancer screening and other kinds of preventive care. However, in many settings, it is simply not optimized for that use. We worked with the National Association of Community Health Centers a few years ago to analyze some of the issues in a variety of different health centers using different electronic medical records. And we found that there are certainly problems with many of the EMRs, but oftentimes the challenges also are among the clinicians and the staff in the organization. So we put together this report that gives some recommendations at a relatively high level about how regardless of which EMR you're using, you can optimize your approach to that EMR. One of the basic issues is that in many places, for instance, if a colonoscopy is done, that report comes back as a fax copy, and maybe it's scanned into the record, but it's put in such a way that it's not searchable. So when you start trying to find out if which of your patients are up to date with colorectal cancer screening, if the information's not in a searchable field, you can't get adequate numbers. So simply making sure that you're putting information on colorectal cancer screening into structured fields is one really big common oversight that leads to challenges using the EMR effectively. And then also using the dashboards and summaries that are often built into these, but don't necessarily include colorectal cancer screening. Having someone within the system who really understands and can work with new staff, new hires, new clinicians to make sure that they're using the information correctly. And then continuing to learn about your system, because the vast majority of systems, 5 years after you start using that system, the system has changed dramatically. And if you're not keeping up, you're not going to be able to use it as effectively. One of the things that an EMR system, or honestly just a simple hand count, can do is give you regular reporting on screening performance. And in every environment where you see significant improvement, you're getting this kind of feedback to clinicians. And you're not talking about clinic-wide or practice-wide screening rates. If you have a multi-clinician environment, you've got to be given this information on a clinician-by-clinician basis. So Doc A needs to see how his or her numbers stack up compared to Doc B and Doc C. And over time, that oftentimes will result in some healthy competition, and it will also begin to eliminate the excuses. Oh, well, our patients are just too difficult. Well, if our patients are too difficult and my screening rate's stuck at 30%, but the person across the hall is screening 65% of their patients, then maybe it's not our patients, maybe it's me. Mailed outreach is another approach that's been demonstrated in a number of studies to be effective. This study from a safety net facility, they mailed, again, invitations to colonoscopy to one group of patients. They mailed FIT kits to another group of patients. And then the third group, they simply left to the usual primary care. They also did some telephone follow-up. And again, at the end of the study period, they found, number one, that uptake among FIT was much higher. So more patients who received a FIT kit in the mail actually completed screening than patients who got colonoscopy. But you can see that those who got an offer for free colonoscopy were still twice as likely to be up to date with screening than those who were left to usual care. But there have been a number of other studies that look just solely at mailing out FIT kits, and with appropriate patient education materials and appropriate follow-up phone calls, reminders, emails, text, you can get a very significant boost. As a matter of fact, there was a study published just within the last 3 or 4 months that called out mailed FIT as sort of one of the underutilized approaches to boosting colorectal cancer screening. Now, another element that cuts across really all of these approaches is screening navigation. And there are a lot of different navigation components. You can also, it's sometimes referred to as case management, but it basically means that you don't just leave it on the patient once you give them a FIT kit or once you give them an appointment for colonoscopy, just leave them to their own devices. You actually do some tracking and follow-up through mail, text, emails, phone calls. You assist patients with scheduling their colonoscopy. You make sure that they know where to pick up the bowel prep, and then check with them prior to the procedure to make sure that they have that bowel prep, that they've arranged a ride. Now, this can entail quite a bit of work, but it also has tremendous payoff. And a number of different studies have demonstrated very significant improvements, including this study in rural Georgia that showed that patients who had a navigation component to their follow-up after receiving a colorectal cancer screening recommendation were 4 times as likely to complete screening. There is a whole toolkit that was developed by some folks in New Hampshire focused around improving colonoscopy completion rates. And patients who underwent navigation to colonoscopy in this manner were 11 times more likely to complete their colonoscopy. So this toolkit is available through the Centers for Disease Control at their website. There's also FLUFIT, which is basically taking advantage of the fact that people who go for flu shots are in a wellness frame of mind. They know that they need to get the flu shot before they have signs or symptoms of flu, that flu shots are preventative. Also, flu shots, by and large, are given to people who are in the same age range as those who need colorectal cancer screening. So you take advantage of that preventive mindset and people showing up asking for something, and then you add in education about colorectal cancer screening and potentially just hand them a FIT kit after you've done appropriate patient screening to make sure that they truly are average risk. This has been studied in a number of different environments. This actually was the initial study that demonstrated the value of FLUFIT. And you can see that within the FLUFIT arm, this was all done in the same clinic, and they chose, I think, 2 days, like Monday and Wednesday were flu and FOBT day. And then if you showed up on a Tuesday or Thursday, you only got the flu shot. And they showed that they had a 29% increase in colorectal cancer screening among patients who showed up on that FLUFIT day. So this really took off and has been replicated in a number of different environments around the country. ACS worked with the original developers of the FLUFIT model and created a how to do it FLUFIT implementation guide. And then there also is a website where you can get information, and your ACS representative there will be happy to work with you if this is something you'd be interested in doing. And now is actually a good time to start thinking about it. It takes a while to put this sort of program in place, and flu shot season, starts in September or early October in most environments. But I will tell you, if you want to do a high quality FLUFIT program, you really need to start your planning in late spring, early summer at the absolute latest. The last thing I was asked to talk about is that the fact that so many patients who have a positive stool test never get to colonoscopy. And this study demonstrated that in a variety of different environments, all of whom were funded, pretty well funded to do colorectal cancer screening, they found that in the best environment where a lot of colorectal cancer screening with stool testing was being done, that still only the best center got follow-up colonoscopy for 83% of their patients. And one of these centers was only had follow-up colonoscopy for 22% of their patients. In most studies, about 1 out of 3 patients who have a positive FIT or guaiac test have no evidence in their record of follow-up colonoscopy. 1 out of 3 patients are missed. Now, how important is that? Well, again, turning back to KAISER, this is a different study, but the same large database that KAISER has. And they found that among patients who were FIT positive, if the time from the positive FIT to completion of colonoscopy was more than 6 months, those patients had an increased risk of both being diagnosed with colorectal cancer and of that disease being at an advanced stage. So if it takes 2 or 3 or 4 months to get a follow-up colonoscopy after a positive FIT, you're probably not doing your patient a lot of harm. But if it does not get done within 6 months, then things go south. And if it is greater than a year, the patient is much more likely to be diagnosed with cancer and to have advanced stage cancer at the time of diagnosis. So going back to that mailed outreach study that I shared with you earlier, showing that a significant number more patients actually chose FIT when it was mailed to them than chose to take advantage of a free colonoscopy offer. Well, in that same study, they looked to see how many patients who had a positive fit actually completed their colonoscopy. And they found that, I believe after a year or 18 months, only 53% of the patients with a positive fit had completed their follow-up colonoscopy. Looking at the results from those patients who did have colonoscopies, they estimated that in those patients who had not had that follow-up colonoscopy, that there were 12 cancers and more than 300 people who likely had polyps. That's based on the findings from those folks who did undergo colonoscopy. So we're talking about some very significant numbers here. A different investigator looked at why does this happen? Why do people not get that colonoscopy done? So she looked at a group of patients, over 1,200 patients who had a positive fit. And then of those found out that, well, some of them never even got a referral to GI. So obviously the colonoscopy is never going to get done. Then of those who got a referral, a significant proportion just didn't show up for that appointment. And then of those who showed up for the appointment, you still had people who dropped out, and even after they saw a gastroenterologist and had an appointment for colonoscopy, still didn't get it done. So the things that have been shown to increase the likelihood of patients completing a colonoscopy after a positive fit. Number one is education. You have to make sure that patients know and understand what a positive fit means for them. And that really should start when they are first making their choice about getting screened. They should understand, okay, you can take this stool test. If this test is positive, you absolutely must follow through and have a colonoscopy. And then documenting the follow-up and the feedback and providing that information back to the clinicians, making sure that somebody is tracking those patients who have positive findings. I'm going to skip over this. And KAISER has developed a really comprehensive model. And KAISER actually is the place where 83% of patients with a positive fit do have documented follow-up. So even putting all these things in place, they still miss a significant number. Now, some of those are patients who simply refuse, but some of it is because of things falling apart in different parts of the system. So what KAISER does is not only is the primary care clinician notified immediately at the time of a positive fit, but the GI lab is also told at that time. So those two different branches of the organization share responsibility for getting patients followed in. They have designated staff whose responsibility is to track these fit positive patients, get them an appointment, and make sure that they show up for that colonoscopy appointment. They also have worked on improving their colonoscopy capacity, because if you tell someone, oh, this test is really important, you absolutely must come and get it, and here's an appointment for 4 months from now, you're giving them kind of a mixed message. And scheduling a screening colonoscopy for 4 months down the line, that's not necessarily problematic. But scheduling follow-up after a positive fit, you really want to get that done as soon as possible so that patients understand how important it is. They also keep a registry to help keep track of all the patients with a positive fit and make sure that they have colonoscopy results. So there are a variety of different things that have been done that can improve this, but it takes investing some time, energy, and effort. There are a lot of different factors at the patient level, at the provider level, and the health system level that can all fall apart and allow these things to fall through the cracks. So it's important that you are aware of these potential challenges and that you try to address them within your environment. So ACS and NCCRT have created a number of different resources to help increase colorectal cancer screening, and I'd encourage you to take a look at these online. You can find them at the nccrt.org website. And then ACS has a wealth of materials around not only colon cancer, but all kinds of cancer issues for both for clinicians and for patients. And you can find those at these websites. All right, I've talked through most of my time, but I think I've got a couple of minutes left to take questions.
Thank you, Dr. Brooks. We do have a couple of questions. First, in regard to the American Cancer Society recommendation to start screening at age 45, but most insurances not covering until age 50. And two-part question, are insurance plans starting to cover at age 45? And then any recommendations and how to address that in practice, that difference in the coverage versus that recommendation?
Yes, there are some insurers who actually are already covering at age 45. We were a little surprised in talking to some of our insurance colleagues at how quickly some adopted this, although most still are not. And a lot of that is because of the way the Affordable Care Act is framed and its focus on the Preventive Services Task Force guidelines. So the thing that will drive in insurance change is if the task force should also change their age of screening. And I will tell you that they are in the early stages of their next evidence review and guideline update, probably a couple of years out from that. The ACS and a number of other organizations did provide a lot of input and information to the task force to consider. And they have the modeling studies that we use that led us to conclude that age 45 screening made sense. So it's going to be slow. For the moment, it's going to be one insurance company, at a time, basically making this decision. I will say that many clinicians have found that if they advocate on the part of their patient for earlier screening, that companies oftentimes will go ahead and relent. The other thing to keep in mind, though, is, again, options are available for colorectal cancer screening. And while most patients are going to be reluctant or maybe not even able to pay, $2,000 or $3,000 for a screening colonoscopy, many of them are maybe quite willing to pay $30 for a stool kit in order to start screening at age 45. If that stool kit turns out to be positive, now that colonoscopy is no longer a screening test, but it's a diagnostic study that should be paid for by insurance. There may be a patient copay, but they should be paying for that follow-up colonoscopy. So that's important to keep in mind. Screening doesn't mean just colonoscopy. So there are other options out there. And the other thing I will say is that even if for a variety of reasons you don't feel that your patients are willing or able to start screening at 45, then the day they turn 50 or the day after, you need to start getting them screened. Because unfortunately right now, for people at the younger end of that spectrum, the 50 to 54-year-olds, less than half of them are up to date with screening. So we've not been doing a good job even with starting people at age 50, although that's been recommended for 25 years or more.
Thank you. As a reminder, if you have a question, you'll need to unmute your line to ask it. And Dr. Brooks, there was a question in the chat box. Do you have an affiliation with Exact Sciences?
I don't have any affiliation. I work full-time for American Cancer Society. Exact Sciences is a corporate member of the National Colorectal Cancer Roundtable, which is a consortium of more than 100 different organizations. So we are well aware of their products and their activities, but we don't have any affiliation from them. And I, as an ACS employee, certainly don't take any money from them.
Thank you. Any other questions from the audience? Again, you can unmute yourself.
I don't have any questions, but I thought this was very helpful information, so I really appreciate it. Thank you.
Thanks, Vanessa. Okay, as a reminder, you will be receiving an email from me with, or not from me, excuse me, from our evaluator with a link to complete the evaluation. And again, it's 4 questions, so please do complete that and help us to determine needs for professional education for the future. Thank you again for your time, Dr. Brooks. Your presentations are always very informative, and I enjoyed it as well.
Thank you. Thanks for the opportunity to share. Take care. Bye-bye all.
Bye-bye.